So I think probably to start the afternoon session, otherwise we'll be a bit a bit delayed in a sense. So we've got two sections this afternoon. So one is just this forum whereby we are going to actually allow our panelists to actually just speak for 5 minutes or so, unless I think some of them would have some presentation to make them probably a bit longer. And after that, we're going to actually open the floor for discussion. This is actually something very informal to actually brainstorm on what are the issues at hand, and so that we can actually discuss them and deliberate them in a broader area, broader depth. And then after that, we are going to actually go to the next speaker, and we are going to wrap up by probably about 3:30. Then after that, we are going to actually discuss the second section of the program today. Okay, I think without further ado, I think you've got the microphone. Okay, can we invite Dr. Aisha first to probably just present, discuss whatever she wants to emphasize on, then probably we can open the floor. Okay, Dr. Aisha.
Thank you, Mr. Chairman. Basically, I think just to even the last mile for us in terms of PCV, we have done everything in terms of submission, and it's going to be a complete package that we have submitted, and it's not just the cost of the vaccine that is considered. All the activities that we need to do before implementation, during implementation, post-implementation will be also considered. And now the most important thing is the bugs that we're waiting for. I mean the funds that we're waiting for. And I believe the minister has asked us whether we are ready if the funds is allocated. I think we are ready, yes.
So it's 10 years running now. I think this is, as you rightly say, is probably the last mile. I think the documents have been up and down and up and down. I think now it's just getting the commitment from the cabinet and also from the finance minister, how to get that amount of funding. So the vaccine cost is one thing, and then the other logistical cost is another thing. I was wondering, have we ever considered getting our GPs, or our private pediatrician or private hospital to also be part of the implementer? Because at the moment, you see, I mean, we are actually just buying the vaccines for the Ministry of Health clinics, and we are going to actually implement that and going to actually provide all the, the infrastructure. But is there any way, because we are talking about how can we actually bring the private sector closer to the ministry? I think there are quite a number of them that can actually deliver. Maybe, is there any thoughts on that?
I think during my presentation, this has been explored at the moment, like Peduli Sihat, right, where the GPs are participating in Selangor. Unfortunately, due to the cost of the vaccine, it's not very popular, because the amount that is allowed in the Peduli Sihat is just 500 ringgit, and that eats up a lot of the funds if they go for PCB, and it's only for one dose after 2 years old. But I believe at the moment the out-of-pocket PCB vaccination is up to 17%. We have actually tried thinking about it, whether to put in the packer, but it was against the putting in of the immunization into packer because of the cost again, the limited amount that is meant for basically the basic health services that is required. I think looking back, the low-hanging fruit that we have at the moment is the government commitment. And initially, I think if you need to involve private sector, you have to have a buy-in policy. For example, I think if we can get a cheaper vaccine, then pool procurement, things like that would be better.
Yeah,
At
because
this moment in time.
this not only for pneumococcal, but vaccination across the board. Because I think we've got a lot of GPs, and they can be, rather than reliant on our maternal and child care clinics, they can actually give the vaccination. You can probably just provide the vaccine to them. They can ensure the cold chain, so on and so forth. And then they can, if there's a co-share kind of thing, they can ask people just to pay for the cost of vaccinating the children, but the cost of the vaccine can be borne by the government. That can actually cut down on a lot of costs for the ministry. Those are, if you want to really look into the integration of the private and the public healthcare, that is actually one of the ways that we can do it at the primary care level. Yeah, maybe Datuk Zul will be probably more, aware of the scenario in the private sector. But I'm not talking about the specialists in the hospitals in Klang Valley. But all over the country, we've got more GPs than sometimes health clinics. Yeah.
Yeah, that's actually a very good idea, and we have to explore this. In fact, this is also the outcome of the EPID review, the EPI review, where the increasing participation of private sector. We need to explore
in primary
this.
care, yeah?
Yeah.
Okay. Maybe Datuk Zul, you want to?
Okay. Bismillahirrahmanirrahim. Assalamualaikum and good afternoon. The private sector, well, I'm actually putting on my private sector hat now. So in the private sector, we will welcome the introduction in the NIP, basically because it will decrease the cost of the vaccine even to us. If the government buys it in bulk, just as what's been happening to hepatitis B vaccine, when the government started introducing it, the cost of the vaccine came down. So we're hoping that the same thing will happen, and that will help with the patients. I must admit, when we first started giving the vaccine in 2006, 2007, the uptake was a bit slow. And we were wondering whether people will actually want to come and ask for it. But now, 2017, we're 10 years, 10 years, we're now 2019, we're 10, 11 years after that. Patients are actually asking for it now. And we have been seeing more cases of confirmed pneumococcal infections, all the pneumonias and all that, because we can do PCR, we can do whatever test easier. So we have the diagnosis, and we can tell patients, and we can actually tell patients what happened to our patients before. Now, if we're going to take, I have some numbers here, right? If we're going to, we look at the uptake of the vaccine from 2014 right up to 2018, okay? The uptake from the private side, which includes the private hospitals and clinic and pharmacy is very small, in 2014 was 144,000 plus doses, all right? And how many doses were given by the government side at that time? 807 doses. This is both brands, okay? 807 doses, a very measly number, okay? But what's happened in the government uptake is doubled every year from then. So much so that in 2018, the uptake was 6,666 doses, right? So, but the private side had also gone up, but not double. It gone up in 2018 to 215,000 doses. So if you were to count this in terms of how many patients actually benefit from it, I've got numbers here that in the private and government together, right? If you estimate that the patient gets 2+1 dosing, which is not what we give. In the private side, we give, for your information, we actually give 3+1 for the kids who are less than 6 months. And then after that, it's 2+1 if it's 6 to a year. We follow exactly according to the leaflet because we don't want to get sued. All right? If anything happens, we get sued and we cannot explain if we give 2+1 or 1+1. All right? So, if you take that, if you take 2+1 doses, all right, then it would have benefited in 2014, both government and private would have benefited about 48,500 children. That's 2+1. But since we're giving 3+1, the number is probably less than that. And 2018, it hasn't even doubled. It went up to 73,976 individual patients. So the number hasn't really gone up fantastically. And if you calculate the number based on the birth cohort, that will come to about 16% of the birth cohort. You're taking a birth cohort of about 450 to 500,000 a year. So it'll be about 16 to 18% of the population. So that's the situation in the private sector. If you want to combine the private and the public sector and we get funding from the public sector, we don't mind that cooperation as long as we get paid. And it will be a workable situation provided everybody's on track and there's no cheating. Everybody wants to cheat now. That's all for now.
Yeah, I think it's very possible because what's happening now, I mean, Ministry of Health, we have actually have made a meeting with the Ministry of Education as well as the Ministry of Defense, and now they are buying medicine in bulk, in a central purchasing kind of thing. So it is going to drive down the cost of medicine even further. So not only that, they're going to actually explore buying of consumables. For instance, stents, we can probably get a very competitive cost if we can actually buy that in bulk. So on that same note, so vaccine is actually in the horizon. I'm sure if we're actually going to actually have this done centrally and incorporating the private as well as the public, the cost is going to come down even more.
This, talking about this bulk procurement, we've been discussing this, and we actually discussed at the ASEAN level, which is higher than this, because I think Thailand is the current, and there is a guy there called Charung. He's a doctor. He was in charge of the Vaccine Institute there in Thailand, and he is very keen to have bulk purchasing for ASEAN, just as it's been done by the PAHO region. PAHO is the Pan American Health Organization. They bought the vaccine in huge amount and they managed to get it at very low prices. So, it's possible for ASEAN to do that, but the trouble is to get to the ASEAN Secretariat and then get them to discuss this instead of discussing trade and discussing, protection of their waters and discussing their borders. They don't want to discuss this all about purchasing. So the only person I know who is closest to the Secretariat is Charung, who is with, and I don't know who is the next ASEAN Secretariat. But I think the government should pursue in that direction because, that's the only way you can get prices at a low rate. You buy it in large billions and millions of dollars worth, and then we give it to each of our countries.
Yeah, I think we should start with MOE, MOH, and the Ministry of Defense. Then I think probably we can explore further. I think it's moving in that direction. I think let's look at it. But I really feel that we could incorporate the GPAs into the immunization program, not only for the pneumococcal, but basic immunization. If we could probably buy the vaccine at a discount when we bulk purchase, and then we could actually distribute this to them, then provided they are paid for their services, I think we can really put to work this public-private partnership, at least on the ground at the primary care level, rather than now they are more like secondary or tertiary care kind of services that they're offering the people. So that's one thing. So do you have any comments from the floor with regards to the pneumococcal conjugate vaccine program. I think the ministry have made it clear, Dr. Aisha has made it clear that we are ready. So we are just waiting for the funding, and then we can kick off and start the program, for Malaysia. Any other comment or?
Yeah, I would like to invite the Bahagian Pembangunan Kesihatan Keluarga, the Family Health Division. The ex-director is also here.
Yeah. Any
because I
comments?
think there were efforts that has been done towards this end. Maybe you can share with us also.
From BPKK, Dr. Amina, the Saidatul. So what are your thoughts? Because you will be the one who will be implementing the program. So what are the kind of challenges that we can share with us? I mean, how far are we in terms of readiness and whatever? What are the challenges? What kind of message are you going to give us? I mean, to prepare us for the eventuality of having this off the ground. At least during this term of the new government, they need to actually fulfill on their Buku Harapan, Book of Hope. That is their manifesto. Buku Harapan by Pakatan Harapan. Is there hope? Okay, Dr. Amina from BPKK.
Okay. How to say it? We have been wanting to have this pneumococcal, as you said before, we've been wanting to have it a long time. Of course, money is the issue. All right. Now, if the money comes in, we do have to prepare all our ground staff. Not only that, now you also have to, number one, you have to decide about the policy, about the immunization, whether you're going to give, at 2, 4, at what age. Because then you also have the issue of the public. Will they accept or not if you're going to give 2 jabs? We also have to think about that. Okay. The other one is awareness. People are not quite aware. As Datuk Zul was saying, the uptake hasn't increased that much over how many years already. Awareness programs has to be in the forefront. We cannot suddenly say, okay, we're going to have... The problem now is like we are waiting for the money to come, but we haven't prepared the public for the eventuality of it, So I think there's a lot of work to do in the planning. So we have to start planning now, before the money comes, so that the implementation will be smooth. Right.
Okay.
If I could add, I think that we have the experience of running new vaccine introduction before. When HPV vaccination was introduced in 2010. We do have experience, and I think if and when the PCV take off, similar example can be learned from the success story. And for example, like Dr. Amina says, very true, the first has to come in is the health promotion, has to go in very strongly, which was not there when HPV was first took off. So I think that the most important thing in the era of anti-vax, to make sure that people accept the vaccine, health promotion has to be in from the beginning so that people will aware and parents will be actually on our side. So messages has to be carefully being taught through. I think that in terms of health staff, it's much easier because we do have mechanism on how to do it. Okay, I think that's what we taught through as implementers. Yeah.
Okay, point taken. We need to actually create this public awareness, education, and making them, be aware and, receptive to the idea of this extra vaccination. So otherwise, the anti-vaxxers are going to probably hold sway. So unfortunately, that's a reality that we need to bear with. But I think the message that we need to actually be putting across is we are advocates for vaccination, for the health of our children. I think a lot of pediatricians here, the majority of you guys here are probably people who are dealing with children. as you go out and talk about immunization, then make them aware that this is actually something that can be given to our children and is going to give a very significant impact to the outcome of our kids. They're going to get less otitis media and pneumonias and meningitis, those kind of things. I think probably it's something which is ongoing. I think the level of trust, public and the doctors are still up there. I think we are the second, or I think probably second. The politicians and businessmen is down there, but we are still okay in a sense. we still have, we still have our opinion still holds sway, in a sense. We can still be thought of as people who provides credible information to our public. Yeah, so I think use that credibility to actually provide this message across that is something which is useful for them. Anyone from the primary care setting, have got any input? Do you think it's going to be a challenge? Pediatricians, anyone want to speak, or do you think it's going to be something of a challenge with these anti-vaxxers coming on board in the community? Anyone from the panelists wanting to add on with regards to the program? Dr. Nick? Thank you very much, Dr. Isham. I think overall we are for vaccinations. I think that's all. I think the pediatricians are there. On the ground level, we know the disease is there. The pneumococcal disease is a burden in the country. I think I'm a bit concerned if we have the idea that pneumococcal is not a major burden in Malaysia. Sort of some ideas that because of the IPD studies that seems to show that our figures are lower than that of other countries. I think we have to be careful. One of it, on the ground level, I think all of pediatricians here, the frontliners will see a lot of cases of pneumonias and pneumonias with complications, with empyema, with all these complications staying long in the wards. Yeah. Those with meningitis who died and also who survived with disabilities. Right. And we notice this number is still huge in the community at the moment. Okay, so we know that IPD studies is also hampered in our countries because the way we are doing it, the way we are isolating it, may not be actually picking up all the cases that is there in the community. But we know that the non-invasive pneumococcal presenting as pneumonia of otitis media or other sinusitis and so on, it's a massive burden. I think it's in the clinic kesihatan, that would be one of the main presentations and the reasons why they come to the hospital, to the clinic kesihatan for treatment. So I think that's the sort of points that we need to the feeling that pneumococcal is a disease with a lot of burden in the country, and that pneumococcal vaccines proven, this is the intervention has been proven worldwide that it is very effective, should be implemented in Malaysia. And it is sad that for the past 10 years we are unable to move this forward because of the issues of affordability and so on. I think at the moment now is like we are the last 52 countries that has not implemented pneumococcal vaccines. There are 142 countries have implemented it. There's only about 52 countries left that has not done it. So I think we need all the efforts, all the pediatricians, the doctors, the public health persons, microbiologists, and so on to push for this to happen, because this appears to be at the moment is the right environment with the right vibes. I think it's in the political arena as well that there is commitment there to get it done. So we probably have to put our efforts together now to push it through finally to get it done and implemented in Malaysia. Yeah, I totally agree with you. Yeah, well said. Yeah, I mean it's kind of ironic, I mean we are quite okay, in terms of implementing the immunization program, and suddenly, we just miss on this PCV. So it's just unfortunate. But I think, as you say, we should actually capitalize on the sentiment and the political support that we seem to be getting, and hopefully it will turn for the better, and we can probably get the funding for us to implement the program. So any comment from
yeah.
Yeah.
Sorry.
Right. Okay. Selva.
Yeah. you were saying about the public-private partnership. Actually, if we look at the model of what polio, polio plus, and I mean, we must engage the charitable organization to come aboard actually and do like what Rotary did for polio at Melinda Bills Gate. I mean, from 1987 till now, we have only about eight notifiable cases in polio in Afghanistan and Nigeria, and this is something that I think we should get these people, for ASEAN-wise, we should get the big companies to come in to sponsor. One is the cost, right? If the cost is the big company sponsor or the big organization sponsors a foundation, perhaps we can bring down the price and we can get more homogeneous and universal distribution of this vaccine. Like what we did for polio, that's one way of looking at it, where increase awareness. Right now, because polio was very, very debilitating actually. So every time they show a video of the old time in 1954, everyone walking around, everyone just brings out and gives the money to the foundation for polio. Similarly, we don't see the impact of invasive pneumococcal disease in children actually. Like some earlier speaker from America said, the social impact is not seen. Whereas you see a person, I mean, I have someone in my own family with polio. I contribute to Polio Plus actually. I know I don't want anyone else in Malaysia to get it. Similarly, we should also engage this kind of big corporation to help us. Perhaps like Prof. Zul said, we should start in the ASEAN region first of all, get these major companies to contribute and see the effect. I mean, if our government alone, the cost might be difficult. Thank you.
Yeah, I think we need to actually get all the help we can get, to put across the message of how important vaccination is, not only for polio, but for other vaccine-preventable disease. In fact, for pneumococcal, it's not that it is not debilitating or, you see a lot of horror stories, with people, very bad pneumonia and, with, chest tubes and thoracotomies and that kind of thing. They stay in the ICU, and we've got people who've got very bad neurological sequelae because of meningitis, second into invasive pneumococcal disease. But this thing didn't get across to the public. Probably it is not as, dramatic as polio, as you may say. But so I think the onus must be on us to actually convey this message across. Yeah, getting organization, NGOs, pharma, or whoever to be on board with this initiative. I think that certainly is a worthwhile thing to actually pursue. Yeah. Dr. Zul, I think we've got a lot of cases. It's just that we don't seem to portray these kind of things in the media that often to actually scare people. Scaring people to actually doing something is probably not a good idea. But sometimes we need to convey across the message that this vaccine preventable disease can be really debilitating and can cause a lot of problems to children. Yeah.
Yeah, that's true. I think you're right. I mean, the public still does not know about pneumococcal disease. I mean, we've been doing this public education, public engagement for what now, 10 years, more than 10 years on pneumococcal disease and pneumococcal vaccine. We talk more about the disease than the vaccine. But recently there was a poll that was sent out to get people to support the idea. It went through social media, and it's been given in English and in Malay. So I think now they've got about 20,000 responses in English and 20,000 in Malay. You know what the response was? Penyakit apa ni? Vaksin untuk apa ni? So, and so somehow, whatever we've been doing hasn't reached out, despite, Immunize for Life, despite positive parenting, despite all the programs that we've been running, somehow it's not reaching the people. And I really don't know how else to reach them. And there are now huge pockets of anti-vaccines. With the place where we had our last Minggu Imunisasi Kebangsaan, the National Immunization Week launch, is a hotbed of anti-vaxxers who didn't turn up anyway. The ones who turned up just wanted to see the minister and give him the little book. So, I'm not sure how we can reach them. Maybe the ministry have got more has got more information, and I was talking to Dr. Jamal. He knows where the anti-vaxxers are, so maybe he can.
Yeah. I think probably our BPKK, our health, the primary care is actually, they've got the infra and also the system and processes in place to provide the, message in the health centers, in the clinics, so on and so forth. It's just that we need to enhance and help them in putting the message across. I think that's why it is something that everybody's work to actually put this across. So that the awareness and the importance of the immunization can be, imbued in the community. So that will be a challenge that we need to together face and provide a solution and answer for Malaysia before we actually embark on the program. So, yeah.
Right time. Previously, probably was because the lack of the vaccine in Ministry of Health. So, sometimes it's a double sword for us, like point the fingers pointing to us. So, now is the time with the right, as you say, the right political commitment, and more people are aware now. So we should be embarking on, this demand generation.
I've been waiting so long to hear you say that.
Okay, I think we are halfway through the forum, which is supposed to be ending before 3:20, I hope. I think the next panelist, I think you've got some slides to show, Dr. Fairuz. I said, Dr. Fairuz. Probably we leave Dr. Susan to the last, because I think she will probably give her wisdom of what's happening because you'll be giving what's happening with regards to our surveillance program in Malaysia. You will be giving some data. Then maybe Dr. Susan can actually have a look of what's happening with our labs, and maybe you can give us some advice on how to carry this forward.
Assalamualaikum warahmatullahi wabarakatuh. I thought my turn will never come because we have been discussing a lot about public health issues and things like that. So, how much time do I have? 5 minutes?
Yeah.
Okay.
Take it from there. We've got half an hour.
Just to talking on behalf of those behind the scene, the microbiologists. We are those belakang tabir, but nevertheless we are important people also. So pneumococcal serotyping surveillance in Malaysia, I think I will skip that in the interest of time. So these activities has been conducted at the Bacteriology Unit, Institute for Medical Research. So after the implementation of vaccine, probably from now on, maybe we have to decide whether it needs to be regionalized or more centers doing this serotyping, so that it's more effective. Right now, we are the only center that does serotyping since 2014. And the criteria for isolates received for surveillance, initially it was all isolates were serotyped, whichever isolate sent to us. But later, because of budget constraint, we limited it to all invasive isolates only from blood and CSF, and non-invasive isolates but penicillin resistant. So we still do serotyping. And isolations are all done at the local hospitals, hospital labs, and the isolates are sent to IMR for serotyping. So this is rather sort of voluntary. So sometimes we do not really get all the isolates that we're supposed to get. And efficiency of sending isolates also is an issue. Okay? By the time it reaches us, sometimes it's not viable anymore. So serotyping is here in IMR, we do it using the Quay-Langs reaction. The antisera is the issue. It's quite expensive, and we need to spend about 50,000 a year just to do serotyping. And we are also optimizing the molecular detection and serotyping for strep pneumo to improve diagnosis as well as serotyping for those non-typable using the antisera. So this is the
publication which has been published in IGID recently in 2019 on the pneumococcal serotype distribution 2014 to 2017. For those who has not read the paper, I just go through a little bit. Serotype distribution during the 2014 to 2017, total isolates we got was 1,847, and 530 of them were those from under 5. 245 were invasive disease, and we found that the common serotypes causing IPDs were 19F, 14-6A, and 23F, 6B also. The top 10 serotypes causing IPDs are all, I'm not promoting PCV13, but it's all PCV13 related strains, which shows that PCV vaccination may significantly reduce the IPD burden. And serotype distribution of the 245 isolates causing IPDs in those under 5, and predominant serotypes 14, 6B, 19A, 6A, and 19F, and 23F. All these are actually serotype distribution is covered by PCV13. And we can see this. I think that this slide has been shown by Dr. Aisha. And a little bit on antimicrobial resistance surveillance. Surveillance data were collected as part of the National Surveillance Antimicrobial Resistance, NSAR. And the isolates most commonly isolated from blood. Actually, 35.4% of those collected were from blood and sputum, and very small percentage were from CSF. I think probably we are missing the cases from CSF because it's difficult to isolate. Sensitivity of culture is quite low in CSF. Maybe we have to think about other methods for diagnosis in such cases. And for the resistance, we are quite okay in terms of resistance. We have very low resistance to penicillin, as well as the third generation cephalosporins like cefotaxime and ceftriaxone, but high resistance with erythromycin and cotrimoxazole. And under this NSAR, actually we gathered data from 2,125 Streptococcus pneumoniae positive cases in 2017. Actually, we had a significant number of cases of strep pneumo infections, actually. So, but for those under 5, in that paper that we published, there is slight difference in penicillin resistance. It is less here compared to those, the overall data in 2017. It was 0.4, but this is 0.2% resistance. But for ceftriaxone, there is a bit increase in resistance to 2.2 compared to the ones on the overall data of 2017. So in summary, we know that strep pneumo is a significant cause of morbidity and mortality, and the incidence of pneumococcal disease highest in children less than 5, as well as adults more than 65 years, and 87.3%, as stressed by Dr. Aisha, of IPDs amongst patients under 5 were caused by vaccine-related serotypes. Antibiotic resistance has increased in many countries worldwide, and the most frequent serotypes showing antibiotic resistance was 6, 14, 19, and 23, which is related to the PCV vaccine-related serotypes. Okay. And in Malaysia, penicillin resistance is very low, and cefotaxime and ceftriaxone and vancomycin resistance are also low. But we have very high resistance to erythromycin and cotrimoxazole. And the challenges in diagnostics and surveillance, for us, the challenge is obtaining high quality samples, and because sometimes patients are partially exposed to antibiotics, so the results of culture may be negative. Because of the high dependency on culture, we may get false negative results. and we may need to include PCR in the future. And obtaining viable isolates for serotyping. In IMR, 30 to 40% of our cases of the isolates that we receive are non-viable by the time they reach IMR. So that is also the challenge. We can't do serotyping for non-viable cases. Probably we might need to do PCR for serotyping in such cases. And the cost for diagnostic and serotyping can be also an issue. And there's limited clinical information. So we need more commitment on the sides of the clinicians, because when we try to publish our paper, it's always a question of where is the clinical data? We don't have enough clinical data. So these limitations may impact on the ability to obtain accurate IPD burden data, assessing the effectiveness of control measures such as vaccination, ability to diagnose IPD in individual patients, and we know that there is an urgent need for improved diagnostic tests for pneumococcal disease, especially tests that are suitable for use in resource-challenged countries. Thank you.
We in the private, we use urine Binax, urine pneumococcal antigen.
Urine.
And although we know the limitations that in children, because even though they are carriers, it will still be positive, but we still use it, and it's nice to have it positive and then tell the parent, hey, your child's got pneumococcal disease. But mind you, we use it when the child has got persistent fever, has got signs in the lungs, high CRP, high white counts. So not just, not just on anything. So, and we have enough evidence, and we tell the parents that they've got, but we don't follow up with the blood culture. Blood culture is done for all the other cases. So, what do you think of the urine Binax test or the urine pneumococcal antigen test? I mean, I know the limitations, and maybe if you could also comment on it, since you're both the.
Yeah.
You want to comment? Because I have no experience with this test, but I know for CSF they do this antigen detection test. But for general IPD,
yeah, for any pneumococcal infection.
Well, the gold standard is still culture.
Nick wants to.
Yeah, we actually looked at that in a pneumonia surveillance program that we were doing. So we're doing clinical surveillance on people with cough and fever that were hospitalized, and they did the urine detection as well as do blood cultures. And so yes, it does pick up some of them, but there were also a lot that it wasn't picking up, and then also just some that didn't have it. Well, there was no evidence of the invasive disease. Doing PCR on the blood or culture, but they were carriers. So it's hard to interpret that. But I think what you're doing is fine to reassure the parents. At least you're giving them something to go by, because having a child in hospital for 3 or 4 days on an IV antibiotic with nothing, no definitive answer is very confusing for a parent. But it doesn't help the cause. So I think I would still advocate blood culture.
Oh yeah, of course, we do the blood culture as well, but then it's just that a lot of the blood cultures we do, I mean, I do a lot of blood cultures in my practice, and a lot of them are negative. But the ones who are positive, I know they're positive, but a lot of them are actually negative.
And the negative cultures, if you're sure about it, do they do PCR?
No.
On them, but now
It's just
you
in
guys,
culture.
do you offer that as a service?
just starting
or?
it. We're just starting it, optimizing the test and.
Yeah, because I know the private labs will easily do a PCR, but the public labs won't. So the NICD is a reference lab for the public laboratory. So we encourage the clinicians to send the blood culture bottle to us, and we will do a PCR, because we can then serotype the data, the isolate as well if we find it. And then at least, you've got a better idea of what you're dealing with.
Yeah, when we get a positive blood culture, I mean, I've got about 3 or 4 that's positive for pneumococcus. I always tell our lab to send it to IMR, to the Institute for Medical Research, to get serotyping. That's not done by some of my other colleagues. So, you know, it has to be, we have actually to teach our own selves that we need to actually get that done. And people are not curious about it, they just want to treat the patient and then go home. So, you know, but I'm a bit more concerned about and I want to know what serotype. So mine have been, all of them 14, and I send them all to IMR for serotyping.
You got back the results?
Yeah, about 3 months later.
3 months later. Because it's a research kind of thing, you know. So that's why it's I mean, yeah. But from Susan, from South Africa, I mean, what do you think that if we are going to do a surveillance program, what IMR is doing, do you think it's enough for us to start the surveillance program?
Well, I think it's a great start, what you're doing, but it probably would be more useful if you get better buy-in from at least the microbiology laboratories.
Okay.
So if you could gather all your microbiologists together and say, please, every single Streptococcus pneumonia that you're seeing, and maybe to lighten your load, make it just the invasive cases, because those are the ones we really, really want to prevent, because that's going to save hospitalization costs and everything. So you want to be able to, I think you need to probably, if you're going to go bigger, you need to decide, maybe let's just focus on invasive disease for now.
And sentinel sites?
Sentinel sites.
Well, so I think decide invasive or
Sentinel
or
sites.
no. So like you've got you doing all pneumococcus. You're trying to collect, and that can be quite overwhelming.
Yeah.
So maybe just choose blood and CSF. And then
That's what we are doing now,
Yes,
actually.
okay, so-
But it's not forthcoming. Many of the isolates are not sent to us, and when they are sent, about 30 to 40% are non-viable, so we can't do anything about
so
it.
that's another thing, is that how are they sending them to you? What are they sending you, the culture plate or?
No.
Okay, so we played around with what's the best way to send these fussy, fastidious organisms, because Streptococcus pneumonia, yes, it grows nicely in the nasopharynx and on the children, but it doesn't grow forever on the culture plate.
Mm-hmm.
So you have to treat it nicely. So we asked the labs to inoculate it onto a Dorset slope and then to incubate it overnight and then send it. And that seemed to have increased our yield a huge amount.
But some do send on slopes,
Okay,
chocolate slope,
okay,
not Dorset.
yeah. So we tried with a number of different media. It seems like
Yeah.
the Dorset
Is the best.
was the best for us. I don't know how easily available it is. But I would also focus on 1 or 2 or 5 of your biggest hospitals, and you need to follow up the whole time with the lab staff and with the clinicians so that they've got buy-in to the program as well. You know, if one day they feel like sending you and one day they don't feel like sending you, you're not really sure what you're going to do with that data. But if you know at these 5 labs, 90% of the isolates are going to be sent to us, you know, you need to invest in those labs. So at least feed back the data to them, go and visit them, because I've also found we try and visit each of the microbiology laboratories once every 2 years, because there's about 200 of them.
Wow.
But it makes such a difference to the technologists working on the benches that they can see your face, they know what they're sending and who they're sending these little Dorset slopes to, and we tell them exactly what we're doing with it, because it's a bit of it's an effort for them to, plus their routine work that everybody is understaffed, and now they've got to go and pick it off and prepare another. So you need to try and show them the value of what of what you're doing. And this is a great time with the potential introduction of the vaccine. You can say, well, we want to show what the true burden is so that we can show the effectiveness of it later on. Another thing is that if you choose your sites, it's best to get denominator data for that site, if you're not, so that you have a good, you can show proper incidence rates of.
So Dr. Aisha, more money for the transport media
Trans-
to transport the organism to us?
Because I presume the cost is, the cost for each test is about 200 per test, is that correct? So you have to be, if you can reduce it to just IPD, that would actually help, in terms of resource allocation. We can, if we can get the money, we can get, because we have incorporated the surveillance cost for this. But I think this afternoon, you need to actually discuss and also confirm, the participation of the Sentinel sites. And we can start with small, and then when it would be a baseline for us, and by reducing from 2,000 over to just 300 something, then that allocation can be re-channeled to the Sentinel sites. So at this moment, of course, we are depending on the money that we applied, so there's no extra allocation for this. So it has to be from the group have to think, this afternoon group, how we're going to fund this project in the beginning, and then later, then it will get, when we get the funds, then it will be channeled towards
Can I
surveillance,
just ask about the Ministry of Health, because there's a list of notifiable diseases that we have to notify, measles and all that. Hand, foot and mouth disease is notifiable. We see it every day, we have to notify every day. The thing is, pneumonia is not. Pneumococcal disease is not. Meningitis is not even notifiable. So, we brought this up with the DG 3 years ago, and nothing has happened. But we were told during that meeting with the DG, there is another list, the syndromic list or something, which I've never seen. And, I would like to report it, and I think that we should report it, because if we don't report it, we get fined 5,000 ringgit. And for fear of getting fined, we all report it. So, and my nurse will always shove the form at me when there's a dengue case or a hand, foot and mouth case. But when I've got a pneumonia, nobody gives me any form. So if we can include that into the list of notifiable diseases, I don't know whether you want to put pneumonia or confirm pneumonia or pneumococcal disease or whatever, but at least it must be so that you can trap that data.
It's a lot, pneumonia.
I mean, that's right.
Yeah.
So that's why I said whether you want to do that.
That's it, it is a lot. That's why if you actually, IPD, it is pneumococcal, then probably you can do that, invasive pneumococcal, as in notifiable disease. So that is something that you can probably bring this up in the meeting, in our NITAC, maybe making invasive pneumococcal disease as a notifiable disease. That would help in terms of surveillance. Of course, we need to.
As I think I presented earlier, it has been discussed and deliberated, and the task force is actually looking into it. Yes, into this. Maybe before we actually putting it as notifiable, then there should be administrative go ahead first, to help with even with these Sentinel's sites.
Yeah.
So we can do that. And
when I remember when hand, foot and mouth disease was put into the notifiable list too, it was only because Chua Jui Ming said that it was notifiable. It didn't require anything more than that. But then when we request about pneumococcal disease, nothing happens. Yeah. And if you do that, the other thing, if you do that, is some of us, like me, probably put the ones that have urinary antigen positive as being pneumococcal disease.
Yeah.
One other question I have for any of the microbiologists here is, are you able to extract data out of your laboratory information systems? So if you chose 5 Sentinel hospitals, could you ask the laboratory that's serving that hospital to pull out all the Streptococcus pneumonia cases on blood, CSF, just to...
Data. Actually, under the National Surveillance of Antimicrobial Resistance, they have the data of pneumococcal disease, the one that I showed. Only for 2017, there's about 800 cases from blood isolates. So meaning that those all of those hospitals have notified to us those cases, and also their antibiotic resistance data also given to us in the via WhoNet. So actually, but the clinical data is missing there. So we only have the laboratory data, and some of the information is not there. So we can't do anything much except reporting the the surveillance data year by year. Every year we report, but nothing more than that can be done because of the lack of clinical information.
So because the reporting does not include clinical information.
Yeah.
And clinicians being clinicians, they are, I think, you couldn't get them to actually provide data unless there's some mechanism. So that's why I think the next discussion, the next section, I think Nick Haruddin and Jaya Selen is going to discuss how can we get this clinical data into the program so that we can actually have clinical data, outcome data together with the lab data. And that will form the basis of our surveillance program in the coming years. So we are going to actually deliberate and see what are the gaps, what are the issues, so that we can actually really provide the clinical data for all of our IPDs. At the moment, asking them to actually go back and look at the clinical notes and trying to extract those information is laborious. It is buried somewhere. And then looking at the writing, no one can actually understand some of the doctor's writing. It's difficult unless the clinicians themselves offer the information. Then that will be easier. Prospectively, I think it's easier, much easier.
Another challenge when we make it notifiable, because very minimal information usually in the notifiable forms.
Yeah.
So further investigation has to be made, and I think here the role of clinicians, because for communicable disease, the inspector or the PPKP, we call it health inspector, will have to go in and get all the information from the doctors. Yeah. So here the information will be, how technical the information is, and I think clinicians have to play a role here in getting all the data so that we can link between the case and the outcome.
Possibly we can get the nursing sister or whoever to provide the data. It's much easier. I see someone from the floor, please.
Good afternoon.
Yeah.
I'm Sitra from Manjung Pediatrician. So actually, I just would like to share, I did a small scale study for my master's thesis. It was on invasive pneumococcal disease. It was a 5-year retrospective study. From 2012 to 2016, I only got 54 cases of IPD, and this was 2 centers, Ipoh and also Serdang. So from there, what I got was the fatality rate was about 20%, respiratory sequel 16%, neurological sequel is about 15% as well. So the thing is that the resistant rates also were different in 2 different hospitals. The KL, Serdang, the resistant rates was about 57% to penicillin, whereas in Ipoh it was much lower. So looking back at all of these data, and I had so much of trouble actually, we tried very hard to get the serotyping from IMR. Out of 54, only 5 children that we could detect the serotypes, and mostly this because of the transportation. When the it's just denatured and we couldn't identify. So this is a retrospective study. When we're looking at a prospective study, I think we have to really think hard about the serotyping, whether how is it. And I think the Dorset method that was introduced by Susan earlier is one way to go, because if we want to prove that our immunization is so important, we actually need to have good data before the immunization to contrast it with the post-immunization. That is one. Secondly, I've joined this group in Facebook, which is called Masyarakat Kena Tahu, which is, they speak a lot of things about vaccines and it's actually a pro-anti-vaccine group. So what they speak about is so hard to challenge, and I just read through to know what they're thinking, so that when I counsel my patients, I know what they're thinking. But the way they put out their story, they said, oh, the doctor said pneumococcal vaccine is good. The first child they gave at only at 2 years old. Then the second child, they gave it earlier, much at 6 months old. But unfortunately, the child became worse. So they keep telling the story where after the vaccine, things became worse. So I anticipate that's going to happen in our population as well. And somehow, people trust Facebook, Masyarakat Kena Tahu much more than MOH or MOE or anything. So I think we really need to penetrate this Facebook and the social media, and I don't know how we're going to do that, but they are really overcoming all of our counseling. It takes me about an hour to talk to a parent to actually agree for vaccination for their children. This is a neonate or whatever, but it's so difficult. I think it's a big challenge, and adding on to our vaccine is going to be a trouble. Another thing is the burden of the disease. Although we only take what is positive, only 54 that I got, but actually I'm sure there's so many more pneumonias that we treat. We do not take a blood culture if the child is not septicemic. So we are missing out a lot of data on Streptococcus pneumonia as well. So we cannot actually translate the burden of the disease to the what's happening in the population. Thirdly, I'd like to say that 48% of my patients actually required ICU admissions, and actually about 30% required ventilation. This is CPAP or invasive intubation. So that is quite a bit as well. And parents who have to stay a median stay of 6 days in the hospital. So putting all this together is actually a cost effective to be actually starting the immunization. And then the next thing is that, like how from Harvard they spoke about the socio-economic demography and things like that. So parents who cannot work, productivity is low, the other children are neglected because of the hospital stay, and some of our patients are really poor, they come really far. So I think all this, we put it together, we really need to get this vaccine going. I would like to propose that it is a notifiable disease. That's what I really, really want. But Taiwan didn't have any challenges, but I'm sure we have a lot. That's all. Thank you.
Just to clarify, Masyarakat Kena Tahu was actually started by doctors. It got hijacked by the anti-vaxxers. So now they've opened up Masyarakat Kena Tahu Ori. That is now from the doctors. But it's good that you're in there and you can put some sense into them.
It's too hard because they are so stubborn with their ideas. I just want to read and spy on them actually right now. I haven't come up with a plan how to go against them. Yeah.
Just a question. Did you publish your antimicrobial resistance?
I've put it up for publication, awaiting for the
59% in Serdang resistance?
57 on penicillin alone. That was.
Did you verify that?
We checked, but that was from my data collection.
That is very worrying. Because we don't seem to be getting that high resistance.
Yeah, but it's a very small scale, and Serdang only had about 19 patients, so maybe it doesn't translate to the whole national population as well. It's a very biased number.
Okay, so all the more reason why I think we are going to get the clinical biologists together. I think we are going to organize that. We've decided on that. So we are going to actually they need to actually discuss on the pertussis aspect as well as pneumococcal. So I think in the coming weeks, we are really going to actually help the clinical microbiologists to come together. And then you're going to actually listen more on the initiative on surveillance. I think Dr. Nick and also Dr. Jayasilan is going to discuss on this shortly. I think for this forum, maybe another question? Okay, please. Yeah.
Just, Mr. Chairman, I'm Dr. Zainal from Public Health Society. So late last year, we have this kind of policy roundtable on PCV. A lot of issue and challenges have been brought up, and we also have some. I think this the policy roundtable was held at the IMU, and some of the recommendations have been sent to government. But here, I want to hear from at least Prime Minister of Health, because at the current situation of government with a tight budget and not so positive perception of the community of the harapan, what janji harapan. So maybe it's not possible to have the large-scale nationwide implementation. So do ministry have some sort of alternative strategy? For example, the focus high-risk group of age group, the focus of high-risk group of community. That's why we maybe you don't have to go to the whole nation, but you choose a few state or a few district or whatever is fine. Because the challenges, one is the money, the budget. Number two is this public awareness. Because ministry must be clear on the target, the objective. You want to reduce the mortality of 5, because it's not that because from 7 to this one is not really something that to be achieved in the few years. And then the problem of focus PCV in terms of stereotyping and in terms of the lab support. So do ministry have something that doable in the next 3 years before the next election? Thank you.
I think at the moment, in terms of giving vaccination to high-risk group, it's already on the card, meaning that we are actually buying pneumococcal vaccine for patients who are high risk. High risk meaning that I think the infectious disease people have actually clarified what constitute high risk, and they are getting vaccination from the Ministry of Health. It is actually been ongoing for a number of years already. But as you're saying that, is there a role of identifying selected group in the community to actually vaccinate? I don't know whether have we got that contingency plan or not. We are just going with immunization, at the universal immunization program. But interesting with what Dr. Lu was presenting in Taiwan. Before they introduced the 2+1 or 3+1 program, they actually gave this vaccine to the high risk group. I think the 2 to 5, they give 1 dose, but they find the reduction, but it's not enough. Then they introduced the 2+1. So they took that 2 years to actually as a contingency matter. I don't know whether the vaccine unit has actually deliberated on this or not, the option, just in case.
Yeah, we have. I think from the experience of the previous introduction of vaccine, we tend to use nationwide rather than pilot implementation. But in view of the cost, that's why this morning I asked Dr. Lu from Taiwan whether they can actually advise us on basic introduction of PCV. But he said that importance is surveillance, what is the current problem in your country, what is the data, and the data, we don't have that data, which actually, what we have is just hospital discharges. So we need to have this data in order to be, to have the strategy of intervention, of basic intervention. So again, I think it would be depending on, how would we go about in putting up to the policy makers in terms of this. But this is actually being under consideration.
Okay,
but at the moment, the amount of money that we apply is actually nationwide. But of course, that would depend on the policymakers whether to have this basic introduction. What I can think of, just like in Peduli Sihat, is actually the bottom 40. seems to be easier because we do have the databases of these children, and if we do go for faces introduction, then that seems to be more logical, because we can't actually identify which area, which state, is high risk or need to have initial intervention. But if we can do a pilot, the problem about pilot is that we need to go nationwide, We have to have the data on the pilot, the outcome of that pilot to go for nationwide. The second issue is equity issue. If IPD is a significant burden in our country, you can prevent more death, you can prevent more morbidity and mortality. So that is also an equity issue if we selectively chose particular states or particular groups.
Okay, Dr. Fong from Sabah, okay?
Yeah, I'd like to bring up, share my experience first of all. Actually, when Dr. Aisha, you mentioned about pilot study. A few years back, I can't remember how many years ago, we did a pilot study with a few centers, with the pediatric infectious disease, with Kaki and all. Was it 2008? 2007. It was a 1 year prospective invasive pneumococcal disease prospective study. That study never got published, unfortunately. And the problems that we had, like you say, of course, you do a prospective is good, but what we encountered was problem like transporting the positive culture to IMR. And like I said, I think less than 50% of our positive culture, were serotype because we couldn't, it was not viable by the time we reached IMR. That was one of the big challenges that we had at that time. Then later on, during the halfway point, we actually implemented the culture media, the broth, to transport, and subsequently the yield was much better. So if we want to do a pilot study, if you don't put in place all these things, it will come back to the same thing again. You won't have any positive culture, the yield is poor, it will be back the same thing. So I think I think we have enough data, evidence, that the need is there for invasive pneumococcal vaccine. For the pneumococcal vaccine for invasive pneumococcal disease. There is the definite need. What we don't see, like you say, very few cases was identified positive from the previous girl, her master's studies. Partly the reason is many of the children who goes to CGP, they were given antibiotic. And by the time they come to the hospital, it will not grow. Many of our meningitis, the CSF, the pneumococcal, the antigen is positive, It was strep positive, but you don't grow it. And then we don't do PCR. So we will lose one case of invasive pneumococcal disease, but will never get included into the statistic. But because it didn't grow in the CSF, was given prior antibiotic, of course it won't grow. So there were many cases like this, That's why our numbers are very small. So it's actually, to me, it's a lot of under-reporting as well. We don't notify all cases until such a time we're going to make it mandatory, the e-notification. And with the e-notification, if we can include data, just like TB and all those things, the clinician, I'm sure, would do that. If it's make it compulsory, we want the good data. We want it, all of us, I'm sure, will need the data, for subsequently looking at a statistic, whether it's coming down or not. Okay, so I think we can easily get the cooperation of most of the clinicians in the room, and also our colleague, our fraternity. I'm pretty sure of that. As long as we make it, we have the data, the questionnaire, everything is ready there, the template is there. Okay, the other thing that I would like to bring up, referring to the question whether to pilot it in certain state or not. So if we do go down that lane, I really think that, we should think about states that have, not many, they are low income. Many of these states are like poorer states, like for example, Sabah, Kedah, Perlis, Many of these, the population cannot afford private care. They won't be able to get the pneumococcal vaccine. If we want to pilot, I think these are the states, the poorest states should be the one given the priority to pilot this one, if you're thinking of piloting it. But of course, I want to go for nationwide, if that is possible. I've been waiting for this nationwide vaccine for so many years, and it's still talking about it. I think it's time for us to go ahead, go forward, thank you.
Okay, we are ready. Okay, take note, Dr. Nick and Dr. Jasilan, so they are ready, they want to provide data. I think we've not heard from Dr. Susan Meiring from South Africa. I mean, can you share with us something with regards to how you do the surveillance program? Because after this, we are going to actually have Jasilan and Dr. Nick to discuss on their plans.
So I have a few slides, I think.
We have a few slides from Dr. Susan Meiring. We are actually now over the 1 hour, so I think probably we are going to stretch it a bit, because I think maybe...
But otherwise I can just speak. There, that's perfect. So
your session is not that long, eh?
Well, it can, yeah.
It can.
Most of the thing has been discussed, actually.
Yeah. Okay. Okay, this is the data from South Africa. Okay, please, Susan.
So in South Africa, we started with the 7-valent pneumococcal conjugate vaccine in 2009, and it was also after long years of deliberation and begging our government. And we introduced a novel schedule with a 2+1 infant dose. So it was given at 6 weeks, at 14 weeks, and then again at 9 months. And this is because it fitted in with the other immunization visits. And we had no catch-up campaign. So in 2011, PCV7 was withdrawn and they replaced it with PCV13. And I think in July 2011, most of our clinics were using PCV13. And we opened it up that if any child came to the clinic that was under 5 years old, that had only had PCV7, they could get 1 dose of PCV13, but I don't think many doses were given out at all. The vaccine coverage for the 3rd dose of PCV7 increased quite rapidly, so 58% in 2009 when we started, up to 62%, and then 2015 it's about 77%, a bit lower in 2016. So it kind of fluctuates. Sometimes there's stockouts, unfortunately, but that's just how things go. So we do this program called Germ Surveillance, and it was started in about 2000, where we, 99, actually when Haemophilus influenza type B vaccine was being introduced into South Africa. And so the surveillance program was started right when the Haemophilus influenza vaccine came in, and we started with Haemophilus influenza and pneumococcal disease and meningococcal disease surveillance at the same time. So we only do invasive disease surveillance, whereas we only we're only interested in cases from blood or CSF or joint or pleural fluid, anywhere where there shouldn't normally be any bacteria growing. And we call it active national surveillance. So every 80% of our population utilizes public hospitals. 20% uses private hospital services. So we cover the 80% of the country. The National Health Laboratory Service is one kind of organization that provides laboratory services for each of the government hospitals. So that's been very useful for us to use that network to access the different hospitals. So every hospital that does microbiology in our country has been told about our germ surveillance program, and they have a case definition of what we're interested in stuck up on their blood culture bench. And any time they identify a Streptococcus pneumonia from a normally sterile site, they then will inoculate that culture onto a Dorset transport slope, and they will send it to our reference laboratory, which is in the Gauteng region, which is kind of the busiest area, the busiest kind of area up north in our country. So the distances are quite far that these specimens have to travel. We ask the laboratories to please incubate the Dorset slope overnight before they send it, and most of the specimens get to us within 2 or 3 days. They're then processed by our reference laboratory, where they do further antimicrobial susceptibility testing, and then they do serotyping. So our reference laboratory is the only laboratory that does serotyping in the country. As well as this asking the labs to submit their isolates, we actually have access to the laboratory information systems that the laboratories use to log in every specimen that comes in and every positive culture. So once a quarter, we actually download all the data for the whole of the country, all Streptococcus pneumonia cases, and we pull out all the bloodstream and all the CSF and all the invasive cases, and we compare that database to our surveillance set. And any cases that haven't been reported to us, we then include in our surveillance data set as an audit case. So we still have the numbers, but we don't have the antimicrobial susceptibility data, and we don't have the serotype data. But it's still useful for looking at overall burden of disease. And sometimes when we do our analysis, we actually impute like the serotypes by age group according to what's been there. And usually we pick up about under 20% of our cases are audit cases. And then of the cases that get sent to us, about 70 to 80% of the specimens are viable. And then we try and resuscitate them on arrival as well as far as possible. And those that aren't, they do PCR directly on the Dorset medium. So that's how our normal national surveillance works. In addition to that, we have 26-ish, 25 there, hospital sites in our whole country. So we've chosen at least one hospital in every province, and there are 9 provinces in our country. A couple of the provinces we have more than one site. And at those sites, we collect the clinical information on these patients. So the isolates that come to us, they come with the name of the patient actually and their age, and that's about it. So their date of birth and maybe their age. But that's quite useful information, just that. But at these 26 sites, we then collect additional clinical information, and we've actually hired nursing sisters to be based at those sites. And so they sit near the laboratory. The laboratory will notify them whenever a case has come up positive, and they will go and find that patient in the ward, and they'll collect additional clinical data. So we get what the patient's travel history has been, what antibiotics they're currently on, what antibiotics they have been on before, what underlying medical conditions they have, and then outcome. They follow them up until they've either been discharged from hospital or they die during that admission. And so we then put that clinical information together with the laboratory information to form our database for data analysis.
Okay, so there's a lot of work to be done. I think there's no denying that we really need to have, the labs on board, and the clinical microbiologists needs to probably come together to actually deliberate on how best to actually move forward. I think we've got our work cut out, you know. I mean, the clinicians have got their role. I think the labs have got their important role as well. And the public health and then the vaccine preventable disease division have got their work cut out as well. And I think as a whole, I mean, we together, our fraternity, and we need to actually work together and come together and provide support to each other so that we can actually see this thing through. And I'm sure, given although the challenges are there, but I think the commitment, the political will is also there. Although there will be some challenges, but I think we can see this through. Hopefully, it will not be a long wait. Certainly, I hope before the next election, we should hopefully see this thing through, and then the wait would be over, and the real job would still continue, because we still need to actually provide surveillance and see how things are moving and tweak the program as and when necessary. It's a long haul, no doubt, but I think we are up to the task. I think as what Dr. Aisha was saying, and as deliberated many times, we are ready. I think with that, thank you the panel members for such an insightful discussion. I think we've learned a lot this couple of 1 hour or so. Can we actually just thank them in the usual manner?